welcome everyone and good morning everyone. In these upcoming few moments I would like to present you my PhD topic, which is in connection with pharmacokinetic and toxicity analysis of vincristine in pediatric malignancies. My name is Dóra Koch. I'm a PhD student from the second department of pediatrics. And my vision is to achieve the best therapeutic effect or response with the lowest possible toxicity when using chemotherapeutic agents, for example, by performing pharmacokinetic modifications. And my mission is to prevent the severe toxicity of chemotherapeutics in pediatric malignancies. So first, we would like to understand the differences between administration routes of a frequently used chemotherapeutic agent called vincristine, and after that, we want to produce some high-quality comparative data in connection with this topic. So, vincristine is a widely used chemotherapeutic agent in pediatric and adult malignancies also. These patients treated with these chemotherapeuticals, they not only have to struggle with a mortal disease, but they have to fight with the adverse effects of the chemotherapeutic agents as well. So it's really important to investigate this field. And the major adverse effect of this drug is neurotoxicity, which is characterized by sensoric, motoric, and autonomic neuropathy. And as you can see, the prevalence of this toxicity is quite high. And for other drugs, for example, doxorubicin, by performing pharmacokinetic modifications, so changing the route of administration, resulted in reduced toxicity with the same therapeutic effectiveness. So our aim is to compare the severity of toxicity in different routes of vincristine administration, the conventional push injection and the continuous infusion. So our clinical question is that does the continuous infusion change the severity of toxicity or adverse effects compared to the conventional push injection? We investigated this question or evaluated this question in all patients treated with this drug, and our primary investigated outcome was the toxicity. Our hypothesis is that the continuous infusion reduces the toxicity compared to the push injection. So we conducted our systematic search in 3 different databases, and on the other side you can see the flow chart of our selection. And before the results, I would like to conclude that because there isn't any comparative data available in the literature, we decided to extract all the data from articles where vincristine was administered and the toxicity, especially the neurotoxicity, was evaluated. This is the results of the first investigated outcome. This is the incidence of vincristine-induced peripheral neuropathy. And we investigated these outcomes in the 2 different groups. So this is the forest plot of the push group. And we can see that the overall proportion or the rate of neurotoxicity was almost 40%, which correlates with the data we can find in the literature. This outcome was also investigated when vincristine was administered as a continuous infusion. And as you can see, the rate of neurotoxicity is almost the same, it's 37%. The next investigated outcome was the incidence of severe neurotoxicity, which is considered grade 3 and 4 neurotoxicity. And we can see that in the push group it was 6%, and in the continuous infusion group it was 3%. So first, to summarize this project, this is the first meta-analysis performed in connection with this topic. These are just the preliminary outcomes we are investigating. We have a lot of other outcomes, and at the end of the analysis, we will have a really detailed information about the prevalence of different clinical manifestations of vincristine-induced neuropathy. And we have a high number of eligible articles and data. That's why we can perform a high number of subgroup analyses as well. And of course, every study has limitations. Ours was that only one RCT was available in this topic. So we, as I already mentioned, we had to extract data from all the articles in which vincristine was administered and neurotoxicity was evaluated. And these are observational and not comparative studies. So in this phase, we can just have some preliminary conclusions. So no significant difference could be detected in the first analysis. So besides the route of administration, there could be other factors which influence the neurotoxicity or the rate of neurotoxicity. So we decided to perform a really detailed subgroup analysis to find these factors or find these possible important factors which influence the rate of neurotoxicity. And as you could see on my plots, the data was really heterogeneous. So the subgroup analysis will give the answers for the heterogeneity as well in our hopes. In this phase, to compose the implication for practice is hard, so it will depend on it depends on the results of the subgroup analysis. And the implication for research is that there is a strong need to perform protocoled randomized controlled trials and to strengthen the evidence by having high-quality comparative data. And there is a strong need for a precise and objective method to evaluate vincristine-induced peripheral neuropathy. And this is why we are performing a clinical trial, a randomized controlled trial in connection with this topic, in which we are comparing two different routes of administration of this drug in pediatric hematologic malignancies. So, as I've already mentioned, strong evidence and high-quality comparative studies are lacking in this field. So, and only one RCT is available. So, this could be a gap-filling study to perform. In this study, we would like to observe the pharmacokinetic differences between the different routes of administration. After that, we want to compare the severity of toxicity in these two administration groups. And in the third point, we want to find some correlation between the observed pharmacokinetic parameters and the toxicity, or the level of toxicity. So regarding to the used acute lymphoid leukemia protocol, we would like to perform a two-arm clinical trial. In the first arm, vincristine will be administered as a 3-hour-long infusion, and on the other arm, it will be administered as a conventional push injection. These are the days of the protocol when vincristine is administered during the induction therapy. And the pharmacokinetic measurements will be done when the first dose of vincristine is administered and when the fourth dose is administered. And to evaluate the toxicity, we are performing an electroneurographic study, which will be performed before the first dose is administered, because we would like to know the baseline electrophysiologic characteristics of the children included in this study. And after that, the second ENG will be performed after the fourth dose of vincristine, because probably some changes can be already seen after the fourth administered dose. And we want to evaluate the late neurotoxic effect of the drug. So a third ENG will be performed half year after the protocol 2, so the reinduction therapy 2. So our clinical question is quite the same, that does the 3-hour-long infusion, continuous infusion, change the severity of toxicity compared to the conventional push injection? And we want to include in this study newly diagnosed children with hematologic malignancies. These are the interventions we want to compare, as you see. And the primary investigated outcome will be the vincristine-induced peripheral neuropathy. Our hypothesis is that the 3-hour-long infusion changes or especially reduces the severity of adverse events, especially the vincristine-induced peripheral neuropathy compared to the conventional push injection. And our clinical implication is the decrease in toxicity. So these are the investigated outcomes. As I've already mentioned, the primary investigated outcome is the severity of the vincristine-induced neuropathy. This will be evaluated by your objective method, as I've already mentioned. And we will evaluate the nerve conduction velocity and the evoked response potential. And we are investigating several other outcomes too. For example, other toxicities.
Excuse me, Dora, the time is up.
Oh,
so
sorry.
Jump to the conclusion, please.
It's just an overview, and thank you for your attention. So tough times will never last, but tough people do. Thank you very much.
For a second, I've seen on the last first plot, the last study was from 1985 or something like this.
Yes.
This is a question, and you also mentioned that there's a huge heterogeneity between the articles. Were there in the, 30, 35 years ago, the way how they administered the therapy, the dosage, or everything was the same? Or there was the change actually the treatment for these patients, and in this case there is no sense to correlate the studies from 30 years ago with the studies from nowadays.
In these studies, so the standard dose of vincristine which is administered is always 1.5 milligram per square meter, and in these studies this was the standard dose also, so I've already checked it. Maybe because you asking the second plot, right?
Tell you the truth, I'm not sure. I'm just seeing for a second. I'm not sure, but there's also from 86 and 84 and so on.
Yes, this therapy has changed, of course, and this is studies in different malignancies. So this is. I don't know which one, but two of them are investigated the outcome in hematologic malignancies and the other one in solid tumors. And of course the therapy has changed and it's hard to compare this, yes.
Okay. Thank you.
But the cumulative dose, which it has a great impact on the severity of neurotoxicity, was higher in this study. So the 4 cumulative dose people got in this study. So this is what I can say for sure.
As I remember good, you show that the incidence of severe neurotoxicity was really low. Do you know the reason behind this?
Yes, thank you for your question. So the severity of neurotoxicity in the articles, and the 80% of the articles are evaluated using the CTCA grading system, which considers severe neurotoxicity as a life-threatening. So grade 3 and grade 4 neurotoxicity is defined as life-threatening neurotoxicity. So the clinic, what we can see in as a clinician, that for example the paresis of a peroneal nerve has a really great impact on the quality of life, but regarding to the grading systems, it's just a grade 1 or grade 2 neuropathy. Yes, so this could be the reason. And in a lot of studies, we just have information that this was the incidence of severe neurotoxicity, and there is no grading system behind it. They just refer what they found as severe, but we don't know the exact background. So thank you very much.